My charge is to share with you the current state of the state with regard to chronic total occlusion revascularization, and I'll do that in a case-based presentation. The benefits of CTO PCI are myriad, but they're very much individualized. They're based on the individual patient, the patient's symptoms, the ischemic burden, the need perhaps to improve left ventricular function, but all of the potential benefits of CTO revascularization are also balanced or offset by variability and uncertainty with regard to the likelihood of procedural success, variability in operator skill set, and also uncertainties overall regarding the likelihood of procedural success versus the potential benefit for the patient, and also misperceptions with regard to indications for the procedure. For instance, we oftentimes have patients with single vessel disease, a chronic total occlusion. The CTO might have been identified 7 years prior. The patient is now symptomatic. A physician will say, well, this patient has very good collaterals to the right coronary artery. And in fact, 7 studies now have shown that by either coronary flow velocity or by FFR, that CTO, the collaterals to chronic total occlusions are sufficient to keep the myocardium viable, but never enough to supply adequate oxygen under demand stress conditions. So what we know today with regard to CTO PCI is that it still remains relatively uncommonplace amongst the domain of PCI procedures, representing approximately 5% or fewer of all PCI procedures at most institutions. And this is in stark contrast to the prevalence of chronic total occlusions, which are identified in at least 20% of the patient population undergoing diagnostic angiography. As I've implied, there are also several misperceptions that are outstanding and persist in clinical medicine, and especially in cardiovascular medicine, regarding the clinical benefit of CTO PCI, interpretation of the angiogram, and uncertainties regarding operator skill set as well as procedural outcome. But what's also commonplace is that CTOs are the most common reason, expectedly, because of the challenges of these procedures for interventionalists, that the most common reasons for referral to bypass surgery, but CTO surgical revascularization is unpredictable. And in fact, even in contemporary trials such as the Excel study with left main revascularization, approximately up to a third of chronic total occlusions are not bypassed by the surgeon. So there's a bit of disconnect in the clinical community that the patient is referred with the intent of CTO revascularization, and yet the surgeon ultimately does not bypass that affected artery, the whole reason why that patient was referred to surgery. And it's very uncommon that we, as practitioners, oftentimes follow up with our surgeons to actually see what vessels actually got bypassed, right? It's commonplace for us to want to know that Mrs. Jones did well after bypass surgery, and our colleague calls us to tell us that, but we don't really ask about, well, which specific vessels got grafted and which ones did not. And what's commonplace then too is that whether it's by PCI, surgical or surgical revascularization, is that the presence of a chronic total occlusion is the greatest predictor of incomplete revascularization. There is increasing evidence basis that supports completeness of revascularization, even more so in PCI versus surgery, for improving patients' outcome. But whether it's with either percutaneous or surgical revascularization, incompleteness of revascularization is independently a predictor of major adverse events over long-term follow-up, compared with patients for whom a complete revascularization is achieved. Now that said, with that background, among experienced institutions with experienced operators, the procedural success rates today approach, if not exceed, 90% for chronic total occlusion PCI, and the in-hospital safety outcomes are comparable to that observed in other complex clinical indications as well as complex lesion subsets. And further, successful CTO PCI, we now know, meaningfully reduces the need for surgical revascularization when it's successfully performed. It reduces the ischemic burden compared with medical therapy alone, and it has a great impact on patient self-reported quality of life metrics, as I'll soon share with you. And altogether, though, the advancement of CTO PCI, however, has been hindered. It's been quite limited of recent by shortcomings in how we as interventional cardiologists conduct trials, how we execute the trials, and in part as a result of these limitations, this has led to a great challenge of the results of the trial and their interpretation. So I'll share with you a case of a 65-year-old gentleman who's a retired engineer with class 4 angina. He has a history of hypertension, hyperlipidemia, type 2 diabetes mellitus, and in 1985 he underwent bypass surgery in his home country of India. And then over a succession of approximately 2 years, he underwent 3 interventions to the same lesion location, a saphenous vein graft to the left circumflex artery. And ultimately, he presented again with recurrent angina, and in January of 2016, the saphenous vein graft was documented to be occluded by angiography. He has moderate left ventricular dysfunction. And over the ensuing next 6 months then, he was hospitalized 3 times for unstable angina. And on 2 of those occasions, when coronary angiography was performed, the results were expectedly the same. The right coronary artery in the left-hand panel is occluded proximally. In the left-hand panel, we can appreciate 2 layers of stents within a vein graft that is now occluded at its origin. This is the vein graft to the left circumflex artery. And it appears, at least with the Judkins left catheter, there seems to be no left main. And by thoracic aortography, there's a hint of some faint filling of maybe a proximal, heavily diseased left main segment here, but effectively the left main appears to be occluded as well. The left internal mammary artery is patent in situ. It was not used as a bypass conduit in the country, in India in 1985, and probably not in the United States as well. And so really the anatomy is characterized on the left as having a single conduit to the heart. And this is a vein graft from 1985, so quite remarkable. And angiographically, it appears, angiograpically at least, relatively healthy, with only mild disease at the insertion at the anastomosis in the left anterior descending artery. And what you appreciate with regard to this angiogram is that there's collateral filling to the distal right coronary artery, and the vein graft to the right coronary artery had been well known to be occluded for some time. For many years, and alternatively, there is some filling in the left, but this is a diagonal branch. And in short, there's no filling, there's no collateral filling visualized to any of the circumflex artery in multiple views. And so this patient was referred, I think appropriately, for a redo bypass operation. And after consideration from our surgical colleagues, and I think Prashant will talk about surgical turndowns in a moment too, but this patient was not considered to be an ideal candidate for bypass surgery. And the reasons were in part the following. Number 1, it would be a redo in median sternotomy. Number 2, there was moderate left ventricular dysfunction, which modestly escalated the risk. Number 3 is that, and number 3 and 4 was that really the culprit vessel, so to speak, for this patient seemed to be the left circumflex artery. He had been free of angina and had no limitations in activity as long as that vein graft to the circumflex artery was open. But now that it's closed, that was foretelling to the surgeons that that was really the vessel that needed to be bypassed. And number 4th reason was that the vessel to be bypassed is not visible whatsoever. And so if you can't see what you need to bypass, there was a great deal of reluctance to put the patient through this risk, not knowing the quality and the health of the distal vessel as well, not being able to see it. And so the patient was ultimately referred, not ultimately, but quickly referred thereafter for consideration of CTO PCI. And I often describe to patients talking about the opportunity for CTO PCI that we think of these as a tunnel that has collapsed in a mountain. And if I were to give a patient a shovel and ask you to dig through this collapsed tunnel, that you'd like to at least know 2 things. Number 1 is you'd like to know where the road is on the other side, right? You don't want to go that way and it really be here. And equally, you would like to know that the other side of the road is a nice big highway, that you pursued through this endeavor to achieve an end result that was leading to something meaningful, not to a small dirt goat path or a small diseased vessel. So we too have the same reluctance and challenges in CTO PCI when we want to go from point A to point B and we just don't know where point B is. And so this gentleman was very thoughtful and persistent with working through us in this, and we pursued then an alternative method of imaging for CTOs, and that's with non-invasive imaging with a coronary CT angiogram. And our colleagues at Piedmont are very experienced in a delayed imaging protocol in which they will image after contrast administration in a timing method so that we can highlight or take advantage of collaterals to see the distal segment of the vessel. It's very interesting when we do this, just anecdotally, because we've had 2 patients I can recall within the past year alone who have been referred from Florida or out of state who have come because they have a CTO and they can't see where the vessel is. And they've had maybe multiple bypasses and grafts are not all marked, and then the patient will undergo a CT and our colleagues will call us back and say, well, the right coronary artery is occluded, Dave, and we knew that, but the vein graft to the right is open, but it just has a tight stenosis in it, and that's why you didn't see the distal vessel. So, and maybe they missed it on the angiogram, for instance. So in this particular instance, though, there was no miss, but there was actually some unexpected findings. Number one is that you can appreciate the saphenous vein graft to the left anterior descending artery, but moreover, is that the left main takeoff is anomalous. It's coming off just off the right coronary cusp. It comes anterior to the great vessels, but that explained the diagnostic challenges at the time of angiography of trying to identify the left main. And when we do delayed enhancement imaging, we again see that the left main is coming off the right cusp, but actually there is a left main segment and it's occluded, and then it's a relatively brief occlusion, and then there's actually a healthy circumflex artery. And so uniquely, we don't see often, not often, but uncommonly, but on occasion, we don't see by angiography adequate collaterals to a target vessel. But when we perform these delayed enhancement imaging protocols, we actually see a very large target downstream. It tells us that there's an artery then to be addressed. It doesn't help us as interventionalists when we still don't know exactly where to go. And so knowing this information, we reviewed it with the surgeons who again said, why don't you try the CTO? And then if that doesn't work, we'll reconsider this. And I appreciate their faith in us in that regard. But actually the history of CTO PCI is very different than this cartoon of the surgeons suggests is, let's just start cutting and see what happens. And in fact, although perhaps considered limited in evidence compared with other lesion subsets and complexities in PCI, with CTO PCI, it has been a storied path of evolution in technology, technique, as well as in clinical evidence itself. And one of the challenges for CTO PCI that has always been raised by the medical community is that perhaps we need a randomized clinical trial comparing CTO PCI versus, for example, medical therapy. And although this has been discussed and debated in the medical literature for some time, how we do such trials in complex PCI raise a number of limitations for me as a clinical trialist and investigator. For example, it was initially proposed that mortality should be the primary endpoint of a study, but should we hold a mid-right coronary artery CTO to a mortality endpoint and opening it up, whereas we don't hold that same standard to a 75% stenosis of the mid-right coronary artery in a symptomatic patient? That is, the true benefit of PCI in most instances is not survival per se, with limited exception, but instead improving a patient's quality of life and symptom burden. And the other challenges in how we do trials, and I'll share with you this just in a few moments, is the consideration of how do we consider patients in CTO trials when we know that the success rate is not so uniformly high. If a patient undergoes an attempted CTO procedure and it fails, are they relegated to the medical therapy arm, or by intention to treat, are they part of the PCI arm? And equally, if a patient is randomized to CTO PCI but doesn't undergo the attempted procedure and just gets treated medically, what happens for them, and what happens for the patients in the medical arm who cross over to CTO PCI? I mean, they really underwent the procedure. Should they not be considered as treated instead of intention to treat? And highlighting all of these challenges and limitations and how we do trials specific to this patient complexity is a recent trial called Decision CTO. Now, Decision CTO was presented as a late-breaking study at the ACC meeting 1 year ago and still to date has not been published despite its submission to multiple medical journals because of the challenges and limitations and the shortcomings, the failures of this clinical trial. Failure not by result, but conduct, by how the trial was conducted. This was a study that was intended to enroll approximately 1,200 patients. Ultimately, it randomized 800 patients at multiple centers in Korea to either CTO PCI or medical therapy alone. Interestingly, the trial was designed as a non-inferiority trial for medical therapy to be non-inferior to CTO PCI. And through 2 years and 3 years of follow-up, and even through 5 years of follow-up, the study demonstrated statistical and numerical parity with regard to the outcomes, demonstrating no benefit in reducing major adverse events with percutaneous revascularization. But as I implied, the trial was quite limited. First of all, because of slow enrollment, the trial was ultimately prematurely terminated at only about 2/3 of its intended enrollment. So it was woefully underpowered statistically for determining its true primary endpoint for significance. Secondly, the investigators, because of slower enrollment, changed the primary endpoint over the course of the trial multiple times. They went from death, myocardial infarction, and stroke, and major revascularization to including health status at one time, and then changing the endpoints again. And further, when they measured health status by the Seattle Angina Questionnaire in this trial, fewer than half of the patients ultimately were represented in that sample size at follow-up. But what's also troubling in this trial is that in the patients who were randomized to medical therapy, over time, 20% of them crossed over to undergo successful CTO PCI, and equally, 1 in 10 patients randomized to medical therapy, 1 in 10 patients randomized to PCI actually just got treated with medicines alone. And further, at the end, there was a similar number of stent revascularization procedures in both groups. And so it also tells you that in the people who were treated with medical therapy, they got treated for a lot of other lesions, which may have been a culprit for much of their clinical outcome and health status as well. And so highlighting this dilemma of how we conduct clinical trials in CTO PCI in what might seem a complicated slide is that by the intent to treat analysis, there was a 1% difference in death, MI, stroke, and any revascularization at 3 years, a 1% difference that actually favored medical therapy and not CTO PCI. But actually, if we continue along a spectrum of per protocol and as treated analysis, so in the final analysis, when we think about, just look at those people who were treated medically and those people who underwent PCI, there's an astounding almost 6% absolute difference that actually favors PCI. And in most trials, this would be highly meaningful and statistically significant. So again, it highlights how we conduct clinical trials. But moving beyond the hard endpoints of mortality or myocardial infarction, for instance, like with most PCI, what we do achieve with successful CTO revascularization is a very meaningful and perhaps most impactful improvement in quality of life for these patients. And it's always, like with most therapies, including TAVR, the sickest individuals who derive the greatest relative treatment effect and absolute treatment benefit from a successful procedure. These are the results of a study that we've recently presented as a late-breaking trial called the Perspective study. Perspective was 500 consecutive patients enrolled at Piedmont Hospital undergoing attempted CTO PCI. And in this study, 90%, we observed a 90% success rate in the 500 patients undergoing attempted CTO PCI. Medtronic is actually leveraging these data for an expanded indication for their drug-eluting stent in CTO PCI, which will be a very novel regulatory pathway for a first time a single center study is changing a product labeling indication. But more importantly to us, in a prospective cohort of 250 patients, we performed at baseline and at 1 year the Seattle Angina Questionnaire. Therefore, we followed their angina frequency, their physical limitations, their treatment satisfaction, their overall quality of life. And what we observed is that at baseline, approximately 70% of the study population was having at least monthly, if not weekly, angina. And through 1 year, it also highlights the durability of a successful procedure that this rate was reduced to 18%. And more specifically, for patients having daily, weekly angina, 40% of them having quite an extensive symptom burden of daily or weekly angina, this was reduced to only 3% at 1 year of follow-up. Now, many have claimed what we have observed, however, in all of these CTO trials where we look at quality of life outcomes too, however, is that interestingly, the patients who have a failed procedure or the patients in randomized trials who are randomized to medical therapy, interestingly, they also have a symptom improvement. They report, ironically, an improvement in their quality of life. And this is not well understood, and it may be perhaps because there's been an intensification of medical therapy, or, well, we failed your CTO, we're adding on more beta blockers and ranolazine and nitrates. Actually, when we look in perspective, that's not the case. The other possibility is that when patients are ultimately referred for a procedure, maybe they're at the nadir of their health status. They're in the worst possible shape that they finally have come in for this procedure. And when it is unsuccessful, perhaps if but anything, it can only look upward after that. It's not certain. Some have recommended a sham-controlled trial of CTO PCI. And interestingly, there is one that is in its very early stages, a small study, comparing, like Orbita, CTO PCI in a sham-controlled design. What's challenging about this, however, is that this trial will also be a failure, and I know Alan spoke to this, I believe, yesterday of Orbita itself, if we underestimate the true placebo effect of a sham-controlled trial. Because what most people don't understand when they think of the sham control itself is the ultimate blinding of a patient. In fact, in many ways, the sham itself is an experiment. How much can I, to be a naysayer, how much can I deceive you into thinking that you underwent a successful procedure to improve to get you to walk a couple more minutes longer on a treadmill, or to report that your health status might be better? And this whole concept of improvement in health status in these patients with end-stage coronary disease is not a new topic, because Jamie Jollis and I, when I was at Duke years ago, studied patients in the angiogenesis trials. These patients, when we published this article, we called these patients ESCD. You know ESRD, end-stage renal disease. We called them ESCD, end-stage coronary disease. And the editors for the American Heart Journal made us change it. They said we were being too negative, calling them end-stage coronary disease. Well, there's a reason to be negative. These were patients in the VEGF angiogenesis trial. There was a sham-controlled study. And these were patients with left main or three-vessel disease and LV dysfunction with rest angina, and were told they had no revascularization options. And when we compared these, and these patients had 40% mortality at 2 years. And when we compared them to a matched cohort of patients who underwent revascularization, interestingly, their healthcare costs were far greater. But interestingly, too, their self-perceptions of health status improved. Sorry, there's nothing we can do for you. Your heart's at the end of the rope. But I'm feeling better next week. It's very difficult. And if we underestimate that improvement, you can see that the sample size for trials to show a benefit are actually larger than a hard endpoint like mortality itself. So when patients come for a consideration of CTO PCI at our institution, they generally ask two questions. And the first is, what's the likelihood of success and safety of this procedure? And I think that based on the collection of evidence that we have to date with CTO PCI, we can share with them that the risk of in-hospital mortality is less than 1%. And put this in context, the ACC-NCDR registry estimates that for saphenous vein graft PCI, that you so commonly perform, is actually 1.5% for in-hospital mortality. For procedural myocardial infarction, and this is by the SCI definition of a CKMB 10 times the upper limit of normal, the estimate from our experience in perspective, as well as other contemporary studies, is less than 3%. And interestingly, in the left main PCI trial, Excel, the MI rate was 3.6%. So we're on par with other lesion complexities. The likelihood of technical success, as I implied, is highly operator and institutional dependent, but at experienced institutions it now approaches 90%, if not exceeds that, and similarly for clinical success. And this certainly represents a remarkable advancement over the preceding decades. And the second question that patients ask is in what clinic am I going to get benefit from this procedure, or how am I going to get benefit? Well, to begin with, it's hard to make an asymptomatic patient feel better, unless perhaps there is a large ischemic burden or high-risk anatomy. And so the most common reason is for symptom improvement. And to date, we have one randomized trial and 6 observational studies with a great deal of scientific rigor that show that there is a benefit in CTO PCI that is at least similar to PCI in non-CTO lesions, if not greater. In other words, that these patients are more limited typically than a standard non-CTO patient, and they actually derive an even greater benefit in symptoms. With regard to event-free survival, we can tell them that even despite the complexity, if the vessel is successfully open, we now have in rigorous trials through 5-year follow-up an estimate that the risk of repeat revascularization of that vessel is less than 10%. And further, we have 16 observational studies that total over 32,500 patients, and again, notwithstanding the limitation of study design, that perhaps survival itself may be improved, and this largely seems to be translational through completeness of revascularization. We also know that there are at least 43 studies that have suggested that CTO PCI can improve left ventricular function, and we're highly dependent, along with our colleagues in imaging, on cardiac MRI for assessment of viability in these patients. We see patients with angiographically, by ventriculography, akinetic, on occasion even dyskinetic segments, but with viability by MRI that can improve as well. There have been 2 recent studies that haven't suggested an improvement in left ventricular function, and that's largely because the baseline ejection fraction was already about 50%. So it's hard to improve upon an already, or demonstrate an improvement if the baseline is already normal. And so we revisit our gentleman, our retired 65-year-old engineer, and we know that he has this anomalous left main, and has this occluded vein graft to the circumflex artery, and we can't see the vein graft. And I said I would be willing to give this a try still, not knowing exactly where we were going to go with this procedure in many ways. And my first attempt with trying this, I went through 7 guiding catheters trying to find this anomalous left main, knowing it was off the right coronary cusp. And I ended up staining the aorta. He had a heavily diseased aorta. And at that point I said, I'm going to quit. It was best not to try to proceed. And so he still was persistent and was willing to undergo another attempt at this. And I allowed him to heal from the initial procedure. And we brought him back the second time, 6 weeks later. And taking advantage of lessons learned, this is an AL2 diagnostic catheter in the right-hand panel. And with in a selected view with thoracic aortography, I was able to find the takeoff of this heavily diseased anomalous left main. And when we do an angiogram with a diagnostic catheter, actually you'll see, even by these collaterals, just a faint segment of circumflex artery filling in below. So at least we knew that there was one line, one vessel here as well. And embarked on this procedure in very much a blind fashion, hoping that perhaps luck would be better than anything in advancing down the path of the artery and help guide us. And you can see there's a simultaneous angiogram through the vein graft of the left anterior descending artery, but it's really of no use because it's not highlighting any of the vessel. We don't see any circumflex artery at all. And there's no collateral, therefore, that's viable for a retrograde approach in this case. Anna, any thoughts then about what to do next? Well, you know, I ask Anna too because we do our procedures, our CTO procedures, most oftentimes in pairs. And we find that really has been advantageous for us. It's a lesson learned from, in part, the airline industry too, where there is no hierarchy here, where you know your partner can tell you, you better stop that now, or you should keep going. And it's good to have another set of hands in place. You know, the airline industry has had this this history of teaching now physicians in these issues, and I think open communication in the cath lab from your staff, from your nurses, telling you how much contrast you've used, reminding you about your radiation exposure, reminding you to check an ACT. I mean, we're very, very teamwork dependent in these procedures. And so yeah, just in this one picture, I thought, Anna, that there'd be perhaps.
And then the other thought is it possible the surface filling via the right coronary?
So
the collaterals to the right to the circ, and you're just not seeing them.
Yeah, good thought. So actually on the initial angiogram that I showed in the very beginning of the right coronary artery occluded, there were no atrial or epicardial collaterals going over to the circumflex as well. But that's a very good thought. There is. So I went through the occluded vein graft. So we use the occluded vein grafts increasingly more common now as a retrograde conduit. These vein grafts are actually very readily crossed by hydrophilic guide wires. And this was as the bailout resort to go through here. And this is, to Prashant's point, this is with a Corsair catheter. And this is crossing through and then taking an angiogram. And now you appreciate that there's quite a large territory in this. And so the procedure now, quite some time into it, is now really just starting to get interesting. And we actually begin with a retrograde approach and are setting up for what we call a reverse cart procedure. But in short, this is just a method of crossing with a guide wire retrogradely into the aorta. And just, you can appreciate in this captured image, the guide wires are just about to meet up with the catheter, and I'm thinking I'm just about home free, and the guide support for all of this was quite tenuous, and everything came out, and I lost everything. And I had spent so much time and X-ray on this case, and operator fatigue set in, that I thought, it's better at this point probably to stop than to start all over again and reconstruct this all over again. And I did something that I've never done before, I think, and I haven't done since. And as a bailout maneuver to this, thinking that I would come back again, and you could argue that I could probably readily cross that vein graft again, I instead stented the whole vein graft. So this had been a long chronically occluded vein graft. It's a class 3 indication by the guidelines, by the way. Don't do it, causes harm. And I thought I got little to lose at this point. I'll just go, vacuum stuff out if I embolize. I didn't post-dilate anything. I just deployed these stents and got out. And now I understand why the patient was so symptomatic too. He had a large ischemic burden related to this territory. And it turns out, though, that the patient then had complete resolution of his symptoms. He was very grateful. He was able to resume his activity. He still remained on a long-acting nitrate, but he came off ranolazine. And the other issue then would be, are we done? Is this the success? But keeping in mind that this vein graft had failed 3 times beforehand, I actually have a 3rd layer of stent in this upper segment, which never fully expanded. You can appreciate up here. And he's asymptomatic. And so, Jeff, is this the end of the story?
Yes.
Yes, it is. Uncle, okay.
Uncle, and now you have the anatomy, so if it closes in the future, the surgeons see where to go.
So I don't know if this is good judgment or not here, but I said, this has failed 3 times before, and a 4th time is going to be introduce all the same challenges again. And so a few weeks later, we brought him back, and the vein graft looks great, and we do simultaneous angiography. You can see that the occluded segment is not the longest, but it's a good distance from here to here. And we cross into the aorta and advance the guide wire you see coming up into the aorta. And I ended up then having to snare this guide wire. It wouldn't go into the receiving antegrade guiding catheter, but we pull the guide wire, the retrograde guide wire, into the antegrade catheter, and this is the final result. And so you see the anomalous left main and circumflex stented, and now, if anything, he has dual arterial supply, and he's well over a year out from this procedure and remains asymptomatic. I don't know if that was the right thing to do. I showed this once at a meeting, and half of the people said absolutely they would do it, and the other half said they wouldn't. And the one thing I would do differently, however, in this case, though, is that if I were to do, when we do this now, and when we use vein grafts that are patent as a retrograde conduit, we typically coil the vein graft. And the reason is that there's emerging evidence from our CTO space that if you have dual arterial supply like this, just like a vein graft to a native vessel, you accelerate either atherosclerosis or restenosis within the stented segment. But you'll be happy to know I didn't bring him back for a fourth procedure. So in summary, CTO patients, they're highly prevalent in our clinical practice. They have substantial symptom burden, and they have high cardiovascular risk. But not all patients with chronic total occlusions by any means require CTO revascularization. And it's sometimes very challenging when patients are calling from California or Florida or Moscow or wherever it may be that they want a CTO done, and you have to tell them, I don't think this is a good one to do. But that said, we're also limited by our evidence basis in the CTO space, and it has to do with patient selection, patient treatment and selection bias in clinical trials, not being able to complete the studies that we initially intended, not being able to, changing our endpoints in the trial as well. Altogether, this has invited a great deal of criticism, and it further undermines the true benefit that we've observed with CTO PCI. And so I think a lesson from our experience, especially in the prospective trial though, is to direct our focus on patient-reported rather than observer-reported health status outcomes. What's been remarkable, it's easy for us to say, he was class 4 angina and today he's class 2. That's just my assessment at a one-time issue. But to ask a patient how they're feeling and to get their true report of their health status is much more meaningful. And if we could focus more in the PCI domain altogether on patient-reported health status, I think this would demonstrate the value of intervention to all interested groups. And I've talked with John Spurtis, who's developed the Seattle Angina Questionnaire, and we were trying to explore ways where, and others are too, if we could incorporate this into our PCI database and show the benefit. I think this would be what would be most meaningful to demonstrate the value of PCI.